It's 4:01 and we'll call to order the Group Insurance Committee meeting. The item 1.02 roll call. Rachel, will you please take roll call?
Okay, Robert Munson.
Present.
Rachel Drake is present. Joseph Silvera.
Present.
Mike Martindale.
Present.
Keith Killian is absent. Brenda Costello. Present. Kaylee Krentz is absent. Gwen Partos. Present. Thank you. Jeff Buzzo.
Present.
Okay, and Jackie Weeb is absent. We do have a quorum.
Great, thank you. Moving on to section 2, our first item is item 2.01, presentation and discussion of Washoe County School District Insurance Internal Service Fund as of December 2025. This item is for information and discussion only. And today, to present this information to us, we have our district's controller, Kyle Rodriguez. Kyle, floor is yours.
Thank you. Kyle Rodriguez for the record. So again, we are going over Q2 financials, so 12/31/2025. You will notice there's slight change in formatting in these financials year over year. So the hope was to more accurately and easily present plan revenues versus plan expenditures or expenses. And then other will consist of interest revenue and then non-plan expenses, such as salaries and benefits, wellness, and miscellaneous expenses. So through 12/31, revenues were relatively flat year over year. You will see that there's a $3 million increase, or 7%. $2.4 million of that is from the prescription rebates. And on the expenses, they are relatively flat, slightly down 2%. The main expenses continue to be the PPO medical and our prescription drugs. With that, the fund still has a 5.6 negative loss for through Q2. Any questions on the income statement for the health insurance fund?
Kyle, hold on a second. Jackie? Welcome. We have a seat up here for you. Mackenzie, thank you for updating the record to reflect Jackie's attendance. So, Jackie, welcome to the committee. Thanks for joining us today. Mr. Rodriguez, our district's controller, was just going over the Q2 financial statements for the health insurance fund. So as of 12/31/25, comparing it to December 31st, 2024, showing that we have a $5.6 million loss in the fund as of December 31st. All right. Did anyone have any questions for Kyle on the health insurance fund income statement? No? All right, Kyle, you can go ahead and keep going along.
So moving to the balance sheet, so page 2, the fund currently has, or as of 12/31, $28 million in cash and investments. The net position of the fund with the $5.6 million loss is now $25.9 million, and it started the year at $31.56. Moving to page 3 will be the wellness fund. So wellness is on the opposite end, it is a relatively healthy fund. Everything is moving along well and not much to report. Any questions? All right.
Not seeing any questions there.
So, and with that, that is all I have to present on the financial statements through 12/31/2025.
All right. Robert?
Robert Munson. I just have a quick question. When we look at our net position of the fund, the overall fund, last year at this time, we had 21, or last year in December was the last date that's on here. We had 21.7 million, and now we're at 25.9, so basically 26. So it looks like about a $2.5 million, maybe close to a $3 million less. Is that the 5% that you're, or excuse me, we have a gain in the net ending. So even with the 5% loss, we've actually gained in our ending fund balance?
So the $5.6 million loss is just this fiscal year. So last fiscal year, the net position year to date was at $9 million. So the net position year over year is higher, over $5 million, correct.
Okay. So the ending balance, the money we have is higher than it was last year, but it's still less than?
Yes, correct. It is, the fund ended, so looking back off of the end of last fiscal year, so the Q3 and Q4 would have went from end of Q2, we were at 20 million, but the beginning net position was 31, so the drastically recovered. So you would have had a $20 million ending net position in 12/31/2024, and then 6/30/2025, you would have had a $31 million net position.
Yeah, so there's a couple things that happened in FY25 that would have impacted this. So at the end of calendar year 2024, we had two very large claims. One was a little over $1 million and one was over $800,000. We typically don't get them that high, and that helped, or that brought down the fund balance considerably in that first half of FY25, the second half of calendar year 2024. Then we had a rate increase that year, which helped bring the fund up. And then the last entry that happens each year is that subsidy from the OPEB trust fund for retiree health expenses. And so that's part of why you see that infusion of over $4 million from May to June at the end of FY25. Any other questions for Mr. Rodriguez? All right, Kyle, thanks for your time today. Okay, moving on to item 2.02, presentation and discussion on staff efforts to expand member outreach and education initiatives for fiscal year 2026, including strategies to promote appropriate health plan utilization and the anticipated impact on plan costs. This item is for information and discussion only and will be presented by Mackenzie Howard.
Thank you, Jeff. Mackenzie Howard for the record. So frequently in many of our conversations in different areas, this notion of education and outreach come up in many of our conversations. And so we wanted to take some time this meeting to highlight why it's important and then what we've been doing over the past year and what we'll continue to do to expand these efforts. So why is education and outreach important when we look at health insurance and wellness? Well, a lot of research goes into this basic public health model, which is primary, secondary, and tertiary prevention. So primary prevention avoids disease altogether. Secondary is early detection of disease, and tertiary reduces complication of an already diagnosed disease. The reason this is important related to education and outreach is mainly in that primary prevention category, because if we can prevent folks from having disease in the first place, the first step to do that is to make them aware of benefits that are available to them and education and understanding of how they can do that. So underneath this chart, we gave some examples related to our biggest campaign last year, which was that PCP campaign. So examples of how education and outreach supported the PCP campaign last year. The reason why we chose the PCP campaign is because PCPs play a central role in keeping people healthy before illness develops, right? So you can kind of see that through line of how that would result in us saving money in the health insurance fund, because if we can prevent disease from happening in the beginning, it's going to save our fund money in the long run. So how do we do this? How do we make people aware? How do we implement education and outreach opportunities? We have a few different channels, communication channels, that is. The first one's the most basic with our email, but we, over the past year, have really aimed to be consistent in this. So many of you are probably familiar with seeing our Wellness Wednesday emails, which go out every Wednesday. Our Benefits Blast, which are a little bit more sporadic, but more targeted, right? The Benefits Blast are specific information that we want you to be aware of. And then last year, we also expanded our retiree email communications. So prior to 2025, once you became a retiree, we only communicated with you via snail mail. And so last year, we had a big initiative to gather folks' retirees' email addresses so we can share information about open enrollment and wellness initiatives that are happening. And the two pictures you see here are examples of those Wellness Wednesdays and those benefit blasts that have gone out. The next channel is through that snail mail, so mailers, posters, postcards, and other snail mail opportunities that we want to engage in. We're going to continue to do outreach. The more times we can communicate and connect with folks, the better, the more awareness they're going to have. The two examples we put up here to show you is the one on the left is what our open enrollment mailer used to look like. This packet used to be about 20 pages long, and it looked like the picture on the left through the entire 20 pages. And last year, our team worked together to revamp it. It has much of the same information, but it looks a little bit more engaging and is hopefully a little bit easier to read, which you can see on the right. The next communication channel is through video. So we know that everyone on this committee engages with health insurance and wellness a little bit more frequently than our population does, but it's still difficult to understand. And so sometimes watching a video explaining our benefits is a lot easier to comprehend than reading something. And so the more types of materials we can get out to folks, that also increases our chance of people understanding and being aware of their benefits. And then the last thing we wanted to highlight for the previous year that we'll continue to work on next year is our on-site support. We know that we can put out as much information as we can, and we'll continue to do that, but what will really drive this primary prevention notion is the relationship building that we can engage in with our members. So last year, we attended as many presentations and tabling events as we could. So we went to contingency day presentations, transportation presentations. We went on site to those specific locations to support that group of folks. We attended secretary academies and our new teacher trainings we tabled at. As many of you know, during our wellness screenings last year, we had 15 events, and we made sure that we had a benefits team member present at all of those sites. Those wellness screenings run from 6 a.m. to 9 a.m. or 10 a.m., depending on the day. And we made sure that at least one person was present to answer questions. And then the next one is during open enrollment. Last year, we completed 434 appointments, virtual appointments, that is. And last year, we launched our benefits hub. So this is the first year that we provided on-site support from the benefits department specifically. And we hosted 17 events, and those ran between 6 to 7 hours each time. Any questions on education and outreach?
This is Gwen. I have a question. So, and I should know this, but the benefits blast, is that emailed to departments to distribute to their employees, or does that go to individual employees directly?
Good question. It goes to all staff, so it goes directly to folks' email. Yeah.
Which, I know there's some correspondence that goes to department heads, and I can't recall when you did your, just
Yeah.
reviewed that, which ones are
The
in that case.
department connections is maybe what you're thinking of. That I think goes to directly to supervisors and principals.
The reason I ask is there's occasions when, I think for folks who are more itinerant, they're not always, there may be some department heads that aren't as diligent
Yep.
in sharing communication in a timely fashion as others.
Totally. Yeah, I think that's why we try to balance the usage of the department connections and the all-staff email to ensure that for folks who aren't getting the information in the department connections, that they're getting it in another avenue as well.
Thanks.
Yeah, thank you.
Mackenzie, just want to say thank you to you and the benefits team for the proactive approach here with the increased support and trying to get folks in for wellness screenings and preventative care to hopefully mitigate a lot of these cost increases we've seen in the health insurance fund in the future. So thanks. Any other questions? Rachel?
Semi-related question, so I hope it fits within the, we are continuing to move forward with the PCP wellness requirement. Last year, there was a great variety in appointments that counted for that wellness screening or wellness meeting with your PCP. Does that still exist, or does it have to be labeled wellness? Because some of the things that we've gotten have been very specific.
Yeah. So I think it does relate to this agenda item because what you're getting at is the actual verbiage of our communication,
Yes.
right? And so all of our communication that we put out to employees is in an effort to build their understanding and awareness of how to navigate healthcare. And so if we continuously put out the correct language of you have to schedule a wellness appointment, the likelihood that they actually schedule a wellness appointment is higher, right?
Yes.
If I list out the laundry list of things you can still earn the discount by engaging
Sure.
in, it's going to confuse them.
Yep.
I believe, right?
Yeah, I'm with you.
So yes, on the back end, we still don't want to penalize people for health
Okay.
insurance coding. That's
Thank
not
you.
fun to deal with. But on the front end, we want to build their capacity
Sure.
and how they go and schedule their appointments. Yeah.
Thank you for the clarification.
Any other questions on this item? Seeing none, we'll move on to item 2.03. That's presentation discussion of the Washoe County School District Engagement and Wellness Report to cover current events and programs as of March 2026. This item is for information and discussion only and will be presented again by Mackenzie Howard.
Thank you, Jeff. So now we get to see some of the outcomes of that communication that we engaged in last year. So every year, typically around March, we meet with our TPA, Anthem, and do an annual claims review. So we're fortunate enough every month to have LP come and give an overview of our spend in our health insurance fund. But once a year, Anthem puts together a very in-depth review of aggregated data of where our spend is going. And so we wanted to share a few takeaways from that report. And the first is highlighting PCP visits. So if we look at the gray box on the left side of the screen here, this calls out what our participation looked like when it comes to PCPs and annual wellness visits. So last year, we had a 56% of our members complete an adult wellness visit, which is what Rachel is referencing. And in 2024, we had 46% of our members engaging in a wellness visit. So if we think back to the last agenda item with the education and outreach we did in encouraging folks to visit their PCP for an annual wellness visit, that was probably a good consistent 7 to 8 months of outreach, and we saw a 10% increase of behavior change, which is pretty remarkable from the benefits team. And then just in general, kind of that health insurance coding that Rachel was referencing, we had 73% of their members complete a PCP visit, so it wasn't coded as a wellness visit, but they were at least visiting their PCP. And in 2024, we had 70% of our members. Both of those call-outs are higher than Anthem's benchmark. Anthem's benchmark is their entire population, which is pretty representative of nationwide. And then the last thing I wanted to call out on this screen is at the very bottom of that gray text box. So we can see that we're not making a PCP campaign just because we want to force people to go to the doctor. It actually results in better health outcomes, and we can see that in our own claim spend. So 79% of our folks who have a PCP have a breast cancer screening on file, compared to 52% of the folks who don't have a PCP on file. So you can see every category of preventative screenings are higher if you have a PCP. This data supports showing that they are engaged in better health outcomes if we have a PCP on file and our folks are engaged with them. The next call out we wanted to make for you all is our telehealth services. And so in 2025, our telehealth visits increased by 15.6%. And this is important because there's a direct financial impact to this. The average cost of a telehealth appointment is $108. The average cost of an in-person appointment, whether that's at your PCP or your urgent care, kind of depends, is $186, and then an ER visit is just under $2,000. So the more that we can encourage folks to still access care but do it virtually, it results in healthy outcomes for our members, but then also good cost savings within the health insurance fund.
Mackenzie, is this the cost to the health insurance fund or to employees?
The health insurance fund.
Okay.
Yep.
Thanks.
All right, and then the last thing we wanted to call out was our top 4 spends. So if we put all of our spend together and put them into health buckets, our top 4 are musculoskeletal, cancer, health status, and behavioral health. And we called out some strategies that we engaged with last year to minimize cost based on these high spends, and we'll continue to do next year. So it involves continuing and expanding our educational awareness campaigns, which we talked about in the last agenda item. Our Be Well Fest vendors, those are intentional. We want as many folks as we can to be there, but we also want folks who are going to support our members with what they're struggling the most with. Our Sydney Health app, more info on that in a few slides, and then also expanding our community partners. You're good, Z. So as many of you know, we expanded our Sydney Health app effective 1/1 of this year. So now it's more of a one-stop shop with EAP and wellness challenges all in one area for our members. So when Anthem came on site, we asked them to bring some preliminary data on what the usage of that app was. And so within the first quarter of this expansion, we had 76% of our members, which is any member on the plan who's 14 years or older, enrolled and registered on the Sydney Health app, and we have 88% of our subscribers registered on the app. The top clicks in the first 3 months of this app being live were My Rewards, so how folks can earn points and therefore some cash. The wellness tile, which is the expanded Sydney Health resources, EAP, and then back to our own benefits website. And then for like a normal update, we wanted to share what's going on in the wellness program. And so many of you are familiar with our Wellness Ambassador program that was pretty popular a few years ago, really before COVID. So we're going to bring that back this year, but we're rebranding and relaunching it to Be Well Partners. We really started putting out opportunities to join this volunteer opportunity in May, and we already have 45 people who want to volunteer for next year. The next one that we launched this year are employee clubs, and so these are opportunities to join in on group bike rides, group runs, walks, and hikes, really however you want to move, just not on wheels. And then also a garden club, and we have some preliminary good participation in this. The reason why these are important is if we think about the wellness wheel and all the different aspects that influence our health, whether that be physical, mental, social, spiritual, so on and so forth, clubs hit a lot of those areas in one shot, right? We're being social, it's supporting our mental health, and in many of these areas, it's supporting our physical health too. Last year, we invited the Mama Van to come here to the admin site. We had one opportunity in 2025. Right after that opportunity, we had very good success here, and so we partnered with them again to expand it. So this year we have 3 opportunities. We've already had 1 completed, and we had 100% completion with our appointments. We have 1 scheduled for July and 1 again in October. And then we wanted to call out our Education Appreciation Week, which just passed at the beginning of this month. The reason we wanted to call this out is because we had over 70 local businesses offer discounts to our employees, and because health insurance and wellness is leading this charge, the majority of these discounts are all for gyms, businesses that support folks' well-being. So a lot of the things that we're funneling them back to is all focused on their health. Few additional upcoming events. We have a Summer Step Challenge on that Sydney Health app, which will run from June 8th to July 6th. Last year, we participated in the Reno Corporate Challenge, and we are signed up to participate again. So 12 of those events will start and end in the month of September. And we did win last year, so we have Northern Division to defend again. But we are signed up and ready to go for that. We'll start outreach for folks to sign up pretty soon. And then we have our Be Well Fest scheduled again at Hug High School, so please save the date for Saturday, September 26th.
Any questions for Mackenzie on this item? I'm not seeing any. Mackenzie, once again, I want to thank you for you and the benefits team, your work on this, specifically the mammogram van. When we found out that was free to us last year, that was a desire I expressed to expand that. So I appreciate you all listening and doing that and getting more events scheduled. I'm sure they're scheduled all over the city throughout the year, so getting more events is a real benefit to our employees. Okay, seeing no other questions, we will move on to item 2.04. This is presentation and discussion of the Washoe County School District Group Insurance Claims Experience Report as of March 2026. This item is for information and discussion only, and we have Nate Kerr with us from LP Insurance today to present this item. Welcome, Nate.
Good afternoon. Nate Kerr with LP Insurance.
Nate, sorry, before you get started, we have two new members on the committee starting today, Mike and Jackie. So if you wouldn't mind just giving a little more explanation on some of these items, that'd be helpful, especially as we get into the item that follows this.
Sure.
Thank you.
Absolutely. I'll do my best. I feel like Kenzie got all the good, fun news and good numbers. So, but yeah, I'll try and provide a little bit more context to what we're going through here. So maybe a good place to start is just a reminder, given that Washoe County School District's group health plan is self-insured, we provide a monthly update on plan performance from a cost perspective. Additionally, where the enrollment is, and then we break that down into a composite cost, which is measurable, and we compare it to the prior period. Again, this report is just the cost side of the house, not the revenue, right? Not the funding. Okay, so here to go over the report through March for Washoe County School District's self-insured group health plan, turning to Exhibit 1. This is our executive summary. Line 1 is employee enrollment. Through the month of March, employee enrollment is up just slightly over 1%, averaging 7,539 employees per month. Line 2, dependent units, is up just shy of 1%, averaging 2,322. Line 3, the total number of dependents is up about 1%, averaging 4,566. And for some of the new members, the difference between the dependent units and total number of dependents is the amount of employees who carry at least one dependent, right? One or more. That's a unit. The total number of dependents is pretty straightforward. That's total belly buttons of dependents. Line 4, net paid claims, so that's the claims cost, taking into account any prescription drug rebates that we get or any stop-loss reimbursements that come in to give us a net overall paid claims. You'll see through the month of March, it's up substantially, about 31%, averaging 8,611,000. We'll get into what's driving that here in a few slides. We then take that number, we divide it by the enrollment to give us our composite cost. And through the month of March, overall composite cost per employee per month is up about 29%, averaging $1,142 in cost per employee per month. Line 6 is fixed cost. That's the cost of administration. Obviously, as a self-insured plan, you still need all of the components to manage a health plan, right? That an insurance company would provide you in a fully insured package. So the cost for our stop-loss insurance, the cost for our third-party administrator, Anthem, our prescription benefit manager, our network, so on and so forth. Those are our fixed costs. Through March, up about 26%, averaging $405,000. Line 7, total plan cost is just adding in fixed and claim cost for a total all-in. Through the month of March is $9,016,000, which is up about 31% over the prior period. And breaking that into a composite is $1,196 per employee per month. Line 9, large claims. We like to report on this just to give a high-level overview of what we would consider a large claim, and what we consider and what we identify as a large claim is any claim that exceeds the 50% halfway mark threshold of your stop-loss deductible. Your stop-loss deductible currently is at $600,000. So anything over 300, we define as a large claim. We start tracking it month over month over month. So line 9, through March, we've had 4. Keep in mind too, just a reminder for some of the newer committee members, last year or year before, help me out, Jeff, 2 years ago, we bumped the spec.
Yeah, I think it was effective 1/1/26. 1/1/25.
1/25, yeah, yeah.
Sorry, thank you.
So 1/1/25, we actually took up this specific deductible substantially up to 600,000, which ended up being a very favorable move for the district, right? You were paying a lot of insurance premium to the insurance company for that coverage that, at least in the most recent historical years, was not being utilized very heavily, right? So you're paying a lot of premium and not getting a lot out of it. So in looking at that, we reassessed, said take on a little bit more liability and stop giving money to the insurance company, right? And that actually panned out. There's a little risk to that because claims performance could open up additional liability for the plan as well. But to date, it's worked out well. Any questions on the executive summary? Turning to Exhibit 2, this is just a visualization comparing revenue versus cost, the blue line being your cost line, the orange line being the revenue line, just to give you an idea not only of how month over month things kind of jump around a little bit, but how the two are tracking in relation to one another. You can see that the far right end of the graph there, we are definitely on a pretty heavy upward cost trend. That's the blue line since November of '25. However, there was an adjustment made for '25 in the funding, so that was a good move. So things are really almost break even in line right now. Turning to Exhibit 3. This is a detailed breakdown of the executive cost summary, so I won't go line by line with all the categories, but I will call your attention to line 4 under employee claims. For the month of March, you'll see a really big number there, $6,265,000. That's compared to the average monthly spend for the prior period, which is the far right on line 4, of $3.5 million. So substantially higher. You can see the first 2 months were kind of right in there. The third month really jumped, and that is due to one very large claim that we had that occurred in March. And we'll get to that in the large claims exhibit. So we add everything in. Again, already mentioned it, but I'll reference it again. Line 35 down at the bottom, far right, gives you a composite cost of $1,196 per employee per month, all in so far for the first 3 months of the plan. Caveat I think I've mentioned before, it's early, right? We only have 3 months. So especially if we have a big month or an unorthodox month from a performance perspective, it makes a big impact. So as we get throughout the year, that should hopefully smooth out. The next many slides is just a breakout by plan. We generally don't go over all the details, but it is there for you in the event you can't sleep tonight and you need help. So I will turn ahead to Exhibit 12. That is our large claims report. Again, just a reminder, any claim over $300,000, we begin to track here. The way this reads is this is a rolling total. It's an aggregate total on a rolling basis, right? So this isn't each dollar that appears in each column isn't new dollars. That is now the new running total. You can see there the first claimant, right, emerged in February at $644,000, and then in March went real big, right? There was $2.4 million. It went up to $2.4 million in total for that member in March. So that's our big claim. I mean, that's the difference right there, right? We were averaging right around 6 million or so, and we're currently at 8. Well, there's your $2 million bucks. Good news, bad news, we do have stop-loss insurance, that's why we buy it, right? So, to that extent, we would expect to see some pretty substantial reimbursement coming back to the plan here soon, right? Stop-loss says anything over 600,000, they'll come in and reimburse you for it, and take over that cost. So we would expect a reimbursement to be coming back to the plan here very shortly, so that's good.
Question.
We have a question over here.
What's the general time frame expected for that reimbursement? I mean, that must be hard to predict, but
Yeah, it's not standardized. Generally, it's anywhere from 30 days in a very quick turnaround up to potentially 4 or 5 months. A lot of that has to do with how complex the claim is, how much back and forth they have to go through on billing and case notes and edits and dual charges, and it also can depend on how long the total complete bill comes in, right, to the TPA so they can process it. Once the TPA gets it and processes it and gets it over to stop loss, it's actually pretty quick. It's just the amount of time it takes to get to that point.
so it would typically come in though within, like, we would expect it within the calendar year.
Oh, yes.
Given that this was March, okay.
Yep. I'll definitely be having heated phone calls if it goes beyond this calendar year. That would be very unorthodox. The other 3 claimants beyond that, you can see we have a new one that emerged in March, 647,000, and then 2 more that are right around 300,000. Without disclosing too much detail, I can tell you that the diagnosis or reason for the first claimant appears to be acute in nature, right? So one-time hit, right? Some of the biggest concerns that we run into in our large claims data is if we have some sort of, for example, maybe a extremely expensive MS medication for multiple sclerosis, right? Well, that's going to be a lifelong treatment. So if it's $2 million so far, well, it's going to be $2 million into the foreseeable future, and that does tend to cause us problems in the stop-loss space. So the good news, getting back to that first one, appears to be acute in nature. We will see as it progresses month over month.
Nate, the problems you were referring to with the stop loss, my recollection is that the insurance company will say, well, this is ongoing. We covered it for that first claim year. We're not going to cover that any longer. And
Yep.
now we're on the hook for covering that. And it can
Correct.
be $2 million a year, but we're not going to get any stop loss reimbursement for that after the first year.
Correct. Generally speaking, the terminology is lasering. Stop loss insurance companies work very differently than a health insurance company. Stop loss insurance companies are insurance coverage for unknown risk. Any known risk, which once a year, one time a year, when we're negotiating the stop loss renewal, they get to open up the books and look at all the data to see what's out there. They've obviously been on the case for a year as well, so they're aware of any claims that have gone down. And any ongoing risk, they will then carve out. That's called a laser. They'll basically say if Nate next year appears that Nate's gonna cost $1 million next year, everybody else's deductible is $600,000, but Nate's deductible's $1 million. Which again opens up additional liability for the plan. Good news is we've negotiated a no new laser provision. It does come with a 50% rate cap, but all details explaining why it just creates complications in the stop loss space when we're trying to negotiate ongoing, very large ongoing claims.
Robert, you have a question?
Yeah, I just, so when we're looking back at Exhibit 2 just quickly, we see that we're down below the baseline, or the linear line, but then we jump up between February 1st and March 1st, this huge increase. And you're saying that a large portion of that are these large claims that just popped up, and we're looking at probably about 1.8 million in reimbursement on that. So if you figured that in the reimbursement, it's a huge increase, but it's not going to be as large as what we're showing here. If we were meeting last month, we would be in February, or 2 months ago, if we were talking just through February, we would be down below the linear line still and looking pretty good for the year.
Yep.
So when we look at this and we go, oh, my goodness, we're above, a large portion of that is going to come back to us. And any further claims on that one or the second one and are going to come back to us. We're not going to be, those are not risks we're going to be taking. Am I correct on that?
That is correct, yes.
Okay, thank you.
Yep.
Any other questions for Nate on this item? No? Okay.
Last exhibit, Exhibit 13. That is simply the amount, as Robert was just alluding to, that we would expect to receive in reimbursement. Those numbers aren't guaranteed or perfect, but obviously we just take the amount over the 600 threshold and give you a total of what is out there potentially. Any questions?
Doesn't look like there's any. Thanks, Nate. So we'll close out item 2.04 and move on to 2.05. This is presentation, discussion, and possible action to provide a recommendation to the Board of Trustees to approve a plan rate increase not to exceed 8% and possible changes to coverage, out-of-pocket maximum deductibles, and co-pays for the Washoe County School District's health plan for the 2027 plan year. This item is for possible action. And I believe, Mackenzie, you're going to lead us off for this item and then hand it over to Nate to go over the presentation.
Yeah. Thanks, Jeff. Mackenzie Harn for the record. Before I pass it over to Nate, because I'll let him have all the fun with this one, I wanted to provide some context, especially for our new folks that are joining our committee. Every year, as Nate mentioned at the beginning of the last agenda item, every month we look at the spend coming out of the health insurance fund, but every year we have LP conduct an analysis on the revenue that's coming in and what that looks like. And then we ask them to pull out their crystal ball and decide what premium rate increase or decrease we need for plan year 2027. So as Nate will describe, a lot of the data we're going to look at is based on a rolling 12-month calendar year. But this year we asked LP to really look at some different options that we could analyze as a group today. We asked them to do that because every year when we have this rates discussion, our committee and everyone involved has a responsibility to maintain stewardship and continuous improvement in the plans that we're offering to our members, but then also how we're running the fund itself. We have a large job to balance both the human aspects of this and the financial aspects of this. And so we asked LP to put that all together in a nice presentation. And with that, I'll pass it over to Nate.
All right. Nate Kerr for the record with LP Insurance. As Mackenzie alluded to, every year, right around this time, we go through the exercise of looking back at the performance of the plan. We take the most recent 12-month window, because that's the most accurate recent data. We add in trend, which is generally a blend of the actual trend performance of Washoe School District's plan and a regional actuarial trend. So we add trend on top of that to attempt to forecast what your costs will be next year, right? We then take that number and we compare it to your current revenue line. Obviously, if next year's costs are forecasted to outpace your current revenue, we would recommend an increase in revenue. So that's what this exercise is attempting to go through and demonstrate. Also, as Mackenzie alluded to, we looked at a little bit different this year. Historically, we have two plans, right? We have a PPO plan and an HSA plan. Historically, we have blended the two. We've looked at them together. There was some considerations this year that maybe we should look at them independently. You are large enough as an organization, as a plan, enough bodies that you do have a substantial amount of credibility in each of those plans. So there is some argument to doing that. In addition, when you have an HSA rate that is lower, right, it's cheaper, and a PPO rate that's higher, and you compare, and you add on the same rate increases over time, that gap starts to widen, right? Just due to the nature of the math. So again, we'll jump into looking at potentially, you want me to drive this one, Jeff?
Yes, please.
Okay. So the first slide here, just giving a little bit of background on the HSA versus PPO, specifically to the categories that I just reviewed, revenue versus cost. So we're looking at each plan on its own. Since 2017, which is when we implemented the HSA, over time, those two have definitely spread apart in their revenue versus cost. And we looked at the window here, this, by the way, March through February, which is mentioned up here, is the window in which we looked at to project cost. That's our 12-month window. During that time, the HSA plan took in approximately $9 million in revenue against $5.3 million in cost for a net position of 3.7. The PPO plan was 77 in revenue versus 80 in cost, so a little bit of a deficit to the tune of 2.6. So again, just giving you an idea that the PPO plan, which is probably not surprising to a lot of us, right? Generally, your higher utilizers, higher risk is going to tend to migrate towards a richer plan design, richer benefits for obvious reasons. So over time, we do see some adverse selection is the term that we use. That does occur when you offer a dual offering like this. Okay, turning to the next page. So again, as I already alluded to, historically, we've looked at the plans combined together. We started there this year, just as a baseline to give us an idea of what we're looking at. The overall needed increase in revenue based on our projection for 2027 is that the district will need to increase the revenue by approximately 5.89%. That is a blend across the spectrum of HSA, PPO, dental and vision. Okay, so that would be a increase to all of those lines of coverage equally in order to meet the costs projection for next year. As a reference point there, the next bullet point down is just giving you an idea that if we were to rate them purely 100% on their own, each plan, the PPO and the HSA, and we looked at that, we would project that the PPO revenue would have to increase 7.9% and the HSA plan would decrease approximately 38%, right? Just to give you an idea of kind of how those two are performing if we looked at them on their own. Obviously, that's a pretty extreme swing, so taking that into consideration and turning the page to page 4, these are the two options that we've put forth on the table. Obviously, the first option is to do what we've always done every year, which is blend the two together, and that's a 5.89%. Or we can break the two apart, but not completely 100% on their own to try and smooth out that transition. Obviously, the idea being that over time, we would like to transition these plans to be performing on their own merit. Obviously, it's pretty extreme to do that all at once, first year. So the compromise, if you will, in that regard is option B, which is to increase the PPO plan by 7.2% and hold the HSA rates as is. Okay, so makes sense. Most of the bodies, most of the cost, most of the premium, most of the dollars are on the PPO, right? So that's why the PPO cost went down just slightly and the HSA went up quite a bit. Questions so far?
Can you go back to the bulleted slide 2 back? Is there a typo in the fourth one down? Okay.
Yeah,
It says PPO twice.
yep. So the HSA
Oh.
is the plan that in the 4th bullet point, the HSA is the plan that would need the 38% decrease.
Decrease,
And the
okay.
PPO would
Yeah.
need the increase, yeah.
Yep, good catch, thank you.
And then quickly on and Nate, I know you'll get to this, but on the options, under option B, I want you all to note that the 7.2 increase is needed on the medical portion of the premium, not on the other components.
So that was a bit of a challenge, well, more than a challenge. We just didn't have access to that data. Anthem doesn't provide the data in that format. That data being, what is the dental enrollment for just the PPO? what is the dental enrollment for just the HSA? They don't have that. It's just dental enrollment and vision enrollment. So when we were looking at breaking them apart and holding them on their own, we did the medical by itself and held dental and vision. And we'll get into some of the rates and what that plays out to look like. Turning to page 5, again, this is a standard process that we go through every year, and that is to provide at least some options to the district from a benefits perspective that could have a potential impact on the cost of the plan. Generally speaking, very general statement, but you have generally 2 levers that you can pull, right, from a cost perspective. It's contributions. How much does the employee pay? How much does the employer pay? And the other one is benefit levels. Obviously, as you take up the deductibles and you increase the out-of-pocket max, that is adding risk to a member potentially, which then would save the plan some funds. So these next few slides are an attempt to provide you a variety of options. Just the way this reads here, obviously we have what the category is in the first column. This first one is out-of-pocket, for example, the out-of-pocket maximum. The second column is where you're at today. That's the current. And then, of course, the potential options that we've put forth is the next column. And then the corresponding expected savings that we would see by making that change and how that translates to a percentage, right? So the idea being, Nate's up here telling you that you need roughly 5.89% more in revenue. For example, if you wanted to try and cut that in half, then you would be looking for roughly 3%, right, in total of some of these changes in combination. Make sense? The next slide is deductible. We tried to focus throughout all these benefit change options. There's obviously a lot more benefit categories than just what we're going to put forth here. But we try and focus on the areas in which have the most impact, right? You can see by looking at any of these categories, you've got to make some pretty big cuts to generate really substantial dollars, right? So could we put, you know, the benefit for durable medical equipment on there? Sure, but it's not going to move the needle. So this is not an all-inclusive, every single benefit on your plan. This is just focusing in on the areas where we think have the biggest impact. Turning the page, this is office visits, both primary specialty, removing the carryover deductible provision, and then the prescription drugs. Obviously, if you increase the copays, same as increasing deductibles or out of pocket, that would generate savings. And I guess I should have clarified those first few slides. That is for the PPO plan, right? For the PPO plan.
Nate, we have a question. Rachel, go ahead.
Could you just remind us all what the carryover deductible provision is?
Fourth quarter carryover?
Yes.
Yeah. Any deductible that you meet in the last few months of the year, carry over to the next year. It's to prevent someone, obviously deductibles reset in January, right? So it's to prevent someone really from being in a very difficult position where they have a surgery on December 25th. They have to pay their full deductible, and then their deductible resets 5 days later. Yeah. The next slide is HSA benefit change options. Again, kept it to just really deductible and out of pocket. As I'm sure many of you know, the HSA plan is actually a lot more basic or simple in nature in the way that it's designed, right? By regulation, the HSA plan, the deductible has to apply to everything other than preventive care, right? So really, you're just dealing with deductible, coinsurance, and out-of-pocket. There's only three categories, 3 kinds of benefit structure for the HSA. Any questions on the benefit options?
Robert?
Just a quick question. When I look at the HSA, it's performing better than the PPO. And then we're looking at possible increases to deductibles there. I mean, if we want to be equitable, wouldn't it be putting in more of this on the PPO than the HSA? Just curious.
Yeah, so can we go back to slide 4, please? So the two options presented here today are option A, which is, we're bringing a new concept here today of looking at just adjusting the PPO plan based on, I think it was slide 2 that showed the differential in revenues versus expenditures for each plan. So option A is continue the process we've been doing where we raise the rates of both plans by the same amount and look at plan design changes for both plans, the HSA and PPO. So that's why the HSA options are here. The other is if we were to look at option B, then we look at getting those plans reset or their revenues reset over time. Or we're just looking at increasing the PPO and only looking at plan design changes for the PPO. I think we're on slide 9. Oh, sorry, Gwen.
So when you showed the next slide, I lost track. Okay, so does that plan design change reflect a 5.89 if we did?
This particular exhibit,
Yeah,
these are simply just changes if you made to the plan, what impact it would have, so. My glasses. So if you, for example, if you increase the out-of-pocket to 7,000 and increase the deductible to 3,500, it would equate to roughly 1.07%.
but it was not the prior one proposal was either increasing both by 5.89 or PPO and then leaving HSA the same. So this is just a third option to increase the HSA a little bit?
I think what Jeff was talking about is we kind of have two moving parts here, right?
I understand, and sorry,
That's okay.
the two moving parts, the two options were either increasing both the same amount or not increasing this one and increasing the PPO. So I'm asking, does this reflect the option of increasing both by 5.89, or you're just kind of showing what the impact would be if you did a rate increase of, I can't quite compute that percentage
Yep.
off the top of my head, but it's,
The latter.
okay.
The latter, yep. This is independent of the actual rate projection for each plan. Now, these numbers are based on the actual plans, right? We're coming up with these dollars and percentages based on the actual performance of each plan, but separate from the revenue.
Nate, if I may, we haven't had this approach in a long time. Robert, was it like 2020, 2019, the last time we adjusted the right. So back at that time, let's say we were faced with a 5% increase, and the committee members got feedback from their members like we're comfortable with 3, but we know we need to get to 5. So we'll raise rates 3%, and then we'll adjust these pieces of the plan, the deductibles and out-of-pocket max, until we get to, on that far right column, options that equal the 2%. So just another way to tackle it, that's not just the straight rate increase, but still getting to the maximum percentage that LP is recommending to increase rates by or adjust the plan by. Does that help?
I think my confusion is just, the way I understand the proposed option A and B, why would we either, this would be a 5.89% increase or 0 increase? If it was option B, it would be 0 increase for this, right?
Yeah, I think maybe the connection you're trying to make there is if you did go with option A, then yes, probably we'd be looking at both. If you went with option B, you'd probably just be focusing in on the PPO changes.
Okay. I guess a long time ago when I did this, many, many years ago, we did have, I can't tell you the year, I could have sworn we did a differential rate increase for the plans we had at the time.
Yeah, that very well could have been. We haven't done that in a very long time here. Because we used to have the EPO plan, which was like the
Yes.
Cadillac
Yep.
plan.
Yes.
But we ended that many years ago as part of the rate discussion because it was an opportunity to, there weren't a lot of people on that plan, and it was really expensive, so we could knock down a couple percentage points off the rate increase by just eliminating that plan.
Just my thought is looking at this and what you've described for the history, it's just gonna increase the difference, right? If rate increases stayed the same, the different net loss from PPO
Right.
is going to, okay.
Robert, did you have a question?
I was just gonna say, all of the stuff that we're talking about with plan changes would reduce the numbers on plan, option A or option B. So all of the stuff here, like, oh, take down 0.04 or take down, but I think on the other one, it was a lot larger numbers, but either way, it's just reducing this recommended amount and, between the two plans, or two options, I guess. And if we add all of those up right there, we don't have very much, but, if you look at other areas, it might make a difference.
Mackenzie, yeah, go ahead.
I think we got there. I just want to clarify that on the deductible for the HSA, that option 1 is required, and that's because of the HSA component and regulations we have to follow regarding the deductible and out-of-pocket max, right? So that part is required of us regardless of what we do on the premium rate side of things, so there will be a slight change.
Rachel?
Okay, so you brought it up, so I'm going to ask the question. The 3,400 as a minimum deductible for the individual is not the federal law. The federal law says it's 1,700, so that's not required. Changing that to 3,500 is not required. I don't understand. Somebody needs to explain this to me in a way that makes sense.
Yeah, sure. I could take a shot at that one.
Great, thank you.
Your statement is correct. The 3,500 and required language related to that number is in order to maintain embedded status for your HSA plan. So I'll back up for a second. HSA plans in particular, the deductible, and when I say deductible, specifically the family deductible, comes in 2 flavors. It comes in an aggregate format or an embedded format. Pretty literal terms, an embedded format means that if you have a family, no one person within that family can ever pay more than the individual amount. That's embedded. Aggregate means it doesn't matter, the number's the number, whether one person has to meet it or all of you meet it. So from a benefit perspective to employees, embedded is almost always more favorable, right? Well, for those who have family coverage, right? If you're an individual, it doesn't matter. So it's a more favorable benefit. The IRS says if you want to maintain an embedded process for your deductible, the individual deductible for your plan has to meet the minimum family deductible for the IRS threshold.
Okay,
So the
thank
minimum,
you, that makes sense.
the minimum family deductible went up just a bit,
Uh-huh.
so that's why our individual deductible has to go up, because those two are intimately linked. Unless you wanted to change the format of the plan.
Right. Okay,
So
Thank you.
probably,
That's-
we don't have enough room, but it probably should say required to maintain embedded status.
okay,
Yeah.
thank you.
Robert?
So my question is, I mean, it's required to the 0.03, which to me, 0.03 is really minimal to the plan, but is that already baked into the percentages, or is that 0.03 going to come off automatically off those percentages, since that's what you're saying is when those changes?
Yeah, we did not bake that in. We're looking at
Okay.
just
so-
the numbers.
So
Yep.
I know it's minimal,
Yep.
but you can take 0.03 off automatically off of either one of those options. Okay.
Okay.
Yeah, so 5.86 and 6. or 7.17. Okay, sorry, Nate, I think we were getting towards the tail end of the tables here. Is that correct? Do you want to keep going?
Yeah, that's the last one, the HSA.
Okay.
That's the last one, benefit changes.
Okay. I think the tables that follow that, if you can go to slide 9, are just the typical rate sheets that we use. So, Mike and Jackie, what this does is say, okay, if we were to, here's the PPO and HSA plans as they currently are, or sorry, the PPO plan, and if we do the 5.89% blended increase, the table at the bottom is the impact to the premiums paid for by the district and by the employee when they have dependent coverage. And then the tables that follow are the similar thing of just looking at current rates versus what are proposed, whether it's the 5.89% or the 7.2% rate increases. Okay. Any other questions for Nate on any of this information? Gwen?
I'm sorry. So this is just showing a 5.89 increase.
Correct.
Do you have one that shows 7.2? Okay.
That should be,
Sorry, getting ahead.
one more slide.
Slide 11, I believe.
Yeah.
Same format here, just again, holding the HSA, dental, vision rates, and just moving the PPO. What would that look like? That's pretty straightforward. You're not making any changes there.
Rachel? All right, see you going.
Okay, so if we could be on slide 10 or 12, either one is fine. Okay, so the HSA contribution for employee that is at the bottom. It was my understanding that the point of the HSA contribution was to kind of cover the difference in what district pays for somebody to be on the PPO plan and what they pay for somebody to be on the HSA plan. The difference in these two proposals is greater than $166. So how are we sitting at $166?
Yep. Do you want to take it, Jeff? You want me to?
I'll let you go and I can
Okay.
chime in if needed.
It was, I believe, last year. I think it was last year. The district made the decision to essentially just freeze the HSA at a flat number, rather than having that variable difference between the plans. You're absolutely right. Historically, that's how they came up with the difference. They would basically just say whatever the difference between the PPO and the HSA is what will provide an HSA funding. The decision was made to just fix that at $2,000 per year.
Correct. So
That's where we get the 166.
Yeah, my understanding on that is that a typical HSA plan, when it is set up, has, here's the flat amount per year that employees receive for the HSA, and then it's typically fixed and maybe readjusted from time to time, whereas for the last 10 years, we've been adjusting it as rates increase. And so district management recommended that it would stay at the flat $2,000 per year starting plan year 2026. And that was, those rates were noted in the discussion from last year.
Okay, so I think that it is worth pointing out that if we are going to address a significant change in what is obviously our PPO folks are getting greater benefit out of their benefits, that this is a piece that we need to look at again.
Can you explain the methodology there? I don't think I'm tracking, and I want to make sure that I'm following with what you're saying.
So we're having a discussion about how right now we are spending more money on folks who are enrolled in our PPO plan. And so we're having a discussion about possibly charging people more for that plan. and which would also mean charging us more for that plan, which means that our HSA folks are not accessing those benefits at the same rate. So, I mean, the difference in the 7.2% and the 0% works to a difference of $255 per month. So to offer our HSA folks just $166 per month, I think is a significant shortcoming in a group that is already subsidizing the group that is accessing the benefits more.
Okay, thank you for explaining that. I'll track with what you're saying there. Robert?
And I think that's pointed out when it says on the typo one where it says HSA would decrease by 37%. I think that is a significant difference. One, you have to raise almost 8%, and one, you could lower 37%. That's almost a, 37 plus 8 is, I don't know, 43, I don't know, 45, I don't know. It's a huge difference in gap, and you were talking about, do we change the rates, what do we do? Well, one of the things to look at is that particular benefit. I don't know, or, because you can't change the deductibles, you can't really change, the deductibles for prescriptions or anything else. You're very locked into those three things, and those are really set. So the only place that you can look to do that is through that rate that's set and how much is given back. So I know that you said that last year they changed that. I don't remember having that discussion at this committee at all to make any recommendations. So management may have made that recommendation to the school board, and they may have made that, but that was not discussed, and that is a planned benefit, which I think is something that we as a committee should be a little bit upset about.
Okay. So adjusting that amount doesn't necessarily have an impact on the tables from slide 2, where there's more revenues coming in for the HSA plan. What that will do is, adjusting that upwards is increased expenses across all funds of the school district. So just want to make sure we have that common understanding. Okay. Yes, Robert.
When we're talking about across all funds of the district, the 5 or 8% or whatever increase we do or choose to do or choose to recommend, we'll have that because the rates are paid by the district for all of the employees already.
Correct. So, and that's something to keep in mind as we have these discussions every year is, look, the last 2 years, the district has had to reduce costs to around 25 to 26 million out of the general fund, and other funds that like grant funds that have flat revenues and get squeezed with increasing employee costs and health benefit costs. So looking at these rate increases, the approach we've taken in the past is just doing a rate increase. That has an impact in the FY27 budget. We projected a similar increase just above this 5.89%. I think it was closer to 6, which resulted in a $2.4 million expense increase to the general fund, which resulted in additional, if we had 0% and only made plan design changes, we wouldn't have had to cut $2.4 million worth of positions out of the budget. And we cut significantly more than that. So I just want to keep in mind that when we look at rate increases versus plan cost and plan design changes, we should keep that in mind because it comes out of everything that we do here. Whether that's the number of the positions we can afford, cost of living adjustments in the future, it all comes out as the first expense along with step increases that come out of the budget. So as we go into those discussions and making recommendations, I think the committee should keep that in mind. Brenda, did you have a question?
Yeah, what is the rough estimate of PPO percentage and HSA percentage?
What do you mean,
How many
percentage of
percent?
members?
Oh, is it on the front? Sorry, Rick, I'll look, thank you.
Mike, we'll get to you in a moment.
It should be on exhibit 3.
Are you asking for the percentage of members on each plan?
Where the
Okay.
enrollment lives?
While we find the specific number, it typically runs around 87% of folks on the PPO and about 13 to 14% on the high deductible.
So Exhibit 6, yeah,
Thank you.
Exhibit 6 will show you who's on the PPO. You've got, on average, so far this year, 6,600 employees. And the HSA, yep, 913. So get back to my comment earlier about where all the bodies are. That's where all the dollars are. You got 6,600 on one, you got 900 on the other.
I think the other thing, because you brought it up, Brenda, that we can call out since we're talking about numbers is the dependent units that Nate mentioned earlier. So on the high deductible, we have 460 dependent units, so more than half of our folks on the high deductible have dependents. And just over 1,800 folks on the PPO have dependents on the plan. So significantly more employee-onlys are on the PPO plan.
Mike, did you have a question?
Just maybe a clarification. I mean, it's not a zero sum for anyone. So what the HSA gains and maybe has 0% rate increase loses in terms of how their HSA contribution competes with the difference between the premiums.
Can you
Follow what you're saying.
So if the $166 per month is to bridge the gap, HSA is giving back that in terms of skin in the game. Whereas they're not getting a 0% increase, but we're part of a whole. And when competing with the gap between costs, HSA is still contributing some to close that gap, although it's not a percentage. Was that accurate?
Sorry, I believe I track with what you're getting at. Okay, any other questions for Nate on any of the figures presented here today? Not seeing any. I know in at least every year that I've been on this committee, we typically do not take any action at this meeting. The group insurance committee members go back to their members and discuss the options that are on the table, and then come back at the next meeting, which will be, I think, on June 24th, to make a recommendation to move on to the Board of Trustees for consideration later in the summer. Gwen, do you have a question?
Your explanation of how things impact the general funds was extremely helpful.
That's good.
I would love to have us be able to share that with my with my association members, but there's no way I would be able to describe what you said accurately. Yes,
okay.
is there any way you could provide that to us? Since
Yeah, let me see what I can put together for that.
Is this presentation recorded?
Yeah.
Yeah, it is.
Okay, so just take that snapshot. And no, just,
You have to do some scrolling.
yeah. Yeah. Anyway, let me see what I can get as far as an explanation for that.
Another way to look at it, Gwen, is on this specific slide, right? At the very top, it says district paid. So you can see that's the specific number that would be coming from whatever fund the employee's salary is funded by. And then the employee paid is the actual amount that would be coming out of the employee's check if they have a dependent.
That is helpful. Somehow tying it into allocations and things so artfully, I think, is very helpful too.
Yeah, I'll try to remember everything I said there.
Don't forget us grant funded.
All right. Okay. So, like I said, we typically don't have an action or a motion on the floor at today's meeting. You all go back to your members, and then we come back and have further discussions and make a recommendation to the board. So we can continue to do that, or someone can have, throw out a motion. So looking around, I don't see anyone with their light on wanting to make a motion. So we won't make a motion on this item, and we will go ahead and close it. That's okay? Or do we need to make a motion to come back to the next meeting to make a recommendation?
It's not necessarily an open meeting issue, it's a rules of order issue. You could make a motion to postpone item 2.05 to the next meeting of the group insurance committee.
Okay. And that's your recommendation?
It is.
Okay. Then we will, entertain a motion to postpone this item to the next group insurance meeting agenda.
This is Rachel Drake, so moved.
Do we have a second?
Joseph Severa, second.
Okay. Any public comment? No? Okay. Any further discussion? No? Okay. All those in favor, say aye.
Aye.
Any opposed, nay? Okay. Motion passes unanimously. Nate, thank you for your time today.
Thank you, everyone.
Can we
Just
take?
about our next meeting, when it's gonna be, you said.
Oh, yeah, I'll get to that at the closing items, yes, okay, got it. All right, that brings us to item 2.06, approval of the minutes of February 25th, 2026 of the Group Insurance Committee. This is for possible action. Do we have any public comment on this item? No? Okay. I guess the only recommendation I would have on the minutes is after roll call, or I guess under the discussion, presentation, and action items, we don't have public comment at the beginning of the meeting, so striking out that paragraph regarding public comment and then where it says no public comment, I think would be appropriate edit for the minutes. All right, any other comments on the minutes? No? Then we'd be looking for a motion to approve the minutes as amended. Robert?
Robert Munson, I move that we adopt the minutes as amended.
Rachel Drake, second.
Any further discussion? All right, all those in favor, say aye.
Aye.
Any opposed, nay? All right, motion passes unanimously. That brings us to our closing items. Our first closing item, 3.01, public comment. Do we have any public comment? No? Okay. 3.02, our next meeting is set for June 24th, 2026. It'll be at 4 p.m. in this room. And finally, 3.03 will adjourn the meeting at 5:25 p.m. Thanks, everyone.